Thanks so much. I don't have slides. When I joined federal government first time I was going to give a talk, they said, you got to get your slides cleared. I said, if I don't have slides, they said, there's nothing to clear. So I haven't used slides in 6 years. I can hack healthcare. So I thought it's actually really terrific to follow such amazing presentations beforehand. I want to talk also about a patient experience and a carer experience, and it was mine. When I actually had to call David Blumenthal, who was going to be my new boss, and I was a little afraid of him. And I had to call him from a hospital family waiting room and tell him that I was going to be late to start my new job. Because my mom had gone into the hospital on what we had assumed, we had just planned for it, right? This is going to be in and out, no problem, elective knee replacement. And I think so many of the features of what happened just 2009, not that long ago, and have really changed since then, I think, for the better, that give me hope in the future. So the first part was, I'm a pretty data-driven guy. I ran the health data shop for Mike Bloomberg and Tom Frieden, and I was sure when we wanted to pick a surgeon for her, that I was going to be able to use my data ferreting skills to find the right, at least hospital, if not surgeon, to do this. It's an extremely common procedure. There's lots of data, right? No. There was no way, there was no transparency for being able to identify even something as simple as surgical volume. Earlier this week, my mom said to me, I need an epidural steroid injection again for her spinal stenosis. And I was able to go on CMS website and pull down for Maryland who are the docs who have the highest volume of doing that procedure. That's been a big change. That's a good change. There's been things like the surgeon scorecard that for all of its problems makes clear that the era of lack of transparency is over for things like this. So how did we choose a surgeon for her? Eminence, right? So we went to the fancy academic medical center, and the really guy who does a lot of, publications and was very well known. And the morning she showed up for her operation, a tool must have been there. Someone did a checklist. And they said, have you stopped the aspirin? That was the only medication she was on. The only medication she was on was an aspirin. And no, she had not stopped the aspirin 7 days before. No one had called her. There was no system, right? And of course, it's the first case of the day. The F-16's on the deck. So they're like, well, we can do it. We'll be fine. And of course, bleeding complications, then infectious complications, and then she starts to have runs of ventricular tachycardia, where her heart's beating so fast, no blood pumps. 10 beats, 15 beat runs, 18 beat runs on the ortho floor. So I hadn't slept in 3 days by her side, trying to do everything I could to help my mom, who I love. And she starts to have longer and longer runs in the middle of the night. And I wanted to see what the cardiologist who'd visited that day had written in her chart. How does it feel when you ask for the chart? I had been used to walking behind the nurse's station. grabbing any chart I wanted. Remember those gray things? But now it was different, because I was on the other side now. And let me tell you, even for someone who's pretty empowered as a physician, who knew the chief resident, who trained across town, like, it doesn't feel like something you're allowed to do. It just doesn't, right? And that paper chart was, I guess the economic term, right? It was rivalrous. You have it, I don't. And people need it. We need it. We healthcare people, we need that chart. What do you want? You want to sue us? What, do you want to get another opinion? You don't trust us? What's the body language? What's the culture when a patient or their family member asks to see the chart? We now have open notes. That's an amazing shift. We now have electronic health records that are not rivalrous. I can see it, so can you. That's been an amazing change for good. And I opened the chart, finally. Screw my courage to the sticking point. I opened the chart, go to the cardiologist note, and it's hard to read the note, okay? But when you can't figure out the legibility of the person's name and beeper number, that's real art. And I couldn't. I could not read their beeper number to understand how to reach this person and what's the plan for my mom. And of course, when she eventually gets discharged, there are tons of exams, and there's a CAT scan that found some fluid collection in a gallstone, and should be followed up as an outpatient for gallbladder removal. Of course, didn't happen. A year later, she has emergency surgery, of course, because there was no outpatient follow-up, because her primary care doc actually never read the chart, right? But when she's finally discharged, that episode, which included lots of complications, lots of additional days in the hospital, bouncing back and forth, post-acute care and so forth. Did the hospital lose money on that complication 5 years ago? They probably made money off of it. Now, we have a 90-day mandatory knee and hip bundle for 800 hospitals in America. That is the collection of those things put next to each other. The data availability and transparency, the ability for patients to get access to their own health records, the ability and the motivation for outpatient providers to care about what happened in the hospital and those transitions of care, and to have the tools and to have the incentive to do those transitions of care. And finally, payment systems that are surely shifting away from just doing stuff to people and towards how are you doing over the entire episode, not just that one service that you're providing. All of those shifts have come in the past 6 years, and the speed of that is dramatic. And in fact, it's overwhelming. Mark asked me to talk about the primary care and outpatient piece of this in particular. And I'm very close to it now. Again, I was in New York, did some policy work for a few years, back now closer to where the care happens, which is terrific. And let me tell you about what we do with our practices when we sign up independent primary care physicians in small practices, not in fancy, large multi-specialty clinics, not in academic medical centers, not part of health systems, independent primary care practices where nearly half of today primary care is still taking place. Here's what we focus on. The first is when the financial model flips, everything changes. And that's just such a basic thing that I can't say enough about how you see the world differently. When we say to them, you should see people the same day, right? It's a patient-centered medical home criteria, access, same-day access, right? And a doc says, but that's disruptive to my practice. And you say, well, if it was a $600 office visit, could you squeeze them in? Like, yeah, but who's paying a $600 office visit? Well, if you prevent them from going to the emergency room and sitting on a hard gurney for 10 hours and talking to people who don't know who they are for something that you could have dealt with in the office, that translates to $600 in savings for the ACO. That flip is so powerful. When you say to them, we're going to really focus on pneumonia vaccinations because, there are a lot of people who come in and who haven't had a pneumonia vaccine, and it's, really could save their life. Let's give that more frequently, more consistently. And one of the docs says, if the patient refuses, does that count? Where does that come from? They've been trained, right? Does that count? Don't ding me, bro. Right? That's what that is. That's saying that there's a compliance exercise going on here, as opposed to, well, no, it doesn't count to preventing the patient from being hospitalized. So no, when it comes to outcomes, that doesn't count. It's a totally different way of thinking, and that is probably changing that culture. Moving towards outcomes away from compliance is probably the greatest gift that we can give to these primary care providers. But more concretely, touching on a few of the key things, the first is identifying and managing those high-risk patients. And one of the gifts that you get when you have one of these accountable care organizations is data. For the first time, we can get the data, not only clinical data that's in the electronic health record, and yes, we pay through the nose to pull it out of those electronic health records, but also the claims data. And to bring those clinical and claims data together is amazing. That's amazing. The second is transitions of care. The goal is that if you don't know when your patient hit the emergency room or got discharged from the hospital, you're not doing population health. So 91% of our practices now get near real-time notifications of when their patients hit the emergency room, when they get discharged, when they go home. That's interoperability that is actually 100% actionable if you work on the workflows to say, now what do I do when I get this alert? We've, nationwide, as you know, the readmission definition has changed. It's up 10%, nationwide up 10%. Among the ACOs, it's down 5% among our ACOs. I count this as being one of the major reasons behind it. Hospital utilization is down 6%. ER utilization down 4%. The third thing is the referral patterns, right? The data availability to be able to say not only who is the highest volume, most skilled at this procedure, but actually what is the utilization pattern? Do you really need to be doing all those that you're doing? What is the standards, the evidence base for you to do those? Do you repeat those tests unnecessarily, as well as cost? So the availability of being able to craft smarter networks, not just the lowest cost, narrow network, but who is the provider who I work with who will get communication back to me, who will be the one that I can be the quarterback of the patient's care with. A lot of the errors that we deal with are errors, the lack of coordination. Who's the quarterback? There are many patients who we need to give them the ability to be their own quarterback, to let their kids be their quarterback. But there are a lot of people who want someone in healthcare to be the quarterback of their care, to say there is someone watching out for me. That someone used to be the primary care doctor. And I think it actually can be again, if those primary care doctors are given the tools, the support, and the financial model that they need to be able to assume that quarterback role. And finally, one of the things that our docs now do that they never did before was actually proactive outreach to patients. Instead of waiting for them to get sick, actually reaching out to them. And this is the piece that I think we're going to have the most improvement in as we get better and better. It's how do we engage patients? How do we make sure that we reach out to them where they are and help them, not just in the course of the office visits, which are a lot more than the hospitalizations, but they're still such a tiny slice of their visits. So my mom has an iPhone now. She loves it. She loves it. She's always on that thing. I had to change my data plan. She can download all her claims data from Medicare, and has, so that now on her phone she can show, she goes to a doctor and she's like, here's my data. And they're like, I don't know what I'm going to do with that, but okay. At least I can see who all your doctors are. I can see what meds you filled. I can see what diagnoses other people have put on you. I can see when you had that procedure. That's not bad. She has a portal that she can go on and read the notes and look at the lab results. Her hospital is part of that bundle, and they're an ACO. And I think her primary care provider, even though they do work in an academic medical center, are getting more of that different way of looking at what the product is of the productivity by which they're measured. So I'm tremendously optimistic, actually, that some of the changes that have occurred in the past 5 or 6 years will lead to changes in the availability of data and on what we do with the data and on changing the financial structures. What I still see lagging behind is the culture, that culture that still says that the best patient is the quiet patient and the best family member isn't there. Thank you.